orthopedic department. I study the foreign students. I'm a surgery and a surgeon in our department, and I read some lections for you. My philosophy of lections told us like this. I don't like so long lections, 45, 15 minutes, not more. Why? After this timing, your brain starts to work and you don't understand anything. And give me the feedback of maybe send me pluses in our chat that of some of you present in the bathrooms nowadays. Now time. No? That somebody of you present in any pubs and drink some well fresh bottle of beer. No? All of you have a work conditions. Somebody give me any plus in a messages. Why you tell me why I don't understand that all of you here? Okay, that's why I understand that you're so passive, and we will start our lecture. First of all, today our topic it's a polytrauma, and then I start to check. Yeah, Banuka, and I know that you're present in the pub now. Yeah, I know this.
Yes, sir.
Mhm. You are single or you have so many friends there. The men who present sometimes in election time in the pubs in the future became in the well surgeons. That's why let's turn to polytrauma, the definition. Oh, how much of happy persons we have here. Okay, polytrauma. First of all, if we speak about the causes of the killers, maybe condition for polytrauma in it's a take maybe have a first place in a so young age group of patients. You see, 1845 years. That's why. That's why it's so uh, it's so important kind of the trauma part. Third most common causes of the death in all groups. You understand why the polytrauma is so actuality when we describe them and when we describe the disturb which happened into the patient's organism, and you understand why we have so high percents of deadly cases with the polytrauma. A great economic and social loss to country. After pandemic and into pandemic time, we start to collect the monies. I don't told you about us, about the humans. I told you about the governments, the countries. And if the government lose too much of monies and maybe lose too much of working period peoples, this is so great economy lose to country. And you see this percent 10 2% than budget, but if our budget who now present in Irish pubs, yeah, for a month maybe I don't know $100, yeah, maybe $1,000, I don't know. The budget of our country it's $1 billion. That's why if you try to sum in what does it mean 2% of them, you have so great number of monies. That's why the polytrauma it's so actuality nowadays. My slides is change. No.
Yes, sir.
Mhm. That's why if we speak about the definition of polytrauma, you check this definition on your slide, but we have too much of different torments, and these different torments usually you can check where in the Russian literatures, in the Russian literature we have a polytrauma, we have a multiple trauma, we have a combined trauma, and sometimes the students don't understand the changing from these three terms. That's why polytrauma definition you can check on your slide. It's not just any number, any high number of fractures, injuries, and any disturbance. It's a problems. It's in the problems in a physio-metabolic layer. That's why usually the polytrauma according with any kinds of shocks any kinds of acidosis and alkalosis, and any great metabolic disturb into the patient's organisms. Or patients with any one combinations of injuries. First of all, if we speak about the definition of polytrauma, it's a localization of fractures in two or more different regions of the patient's body. For example, if our patient have a fracture in the forearm and in a hip area, it's a polytrauma. No, it's a multiple fracture of upper extremity. But if our patient have a fracture of femur, for example, mid shaft and problems in the first toe in the right or left palm, it's a polytrauma. I understand that maybe the layer of this of hardening of this trauma is not so high, but generally it's a polytrauma. What does it mean? Uh, Multiple trauma. It's a fractures in the same extremity. What does it mean combined trauma? For example, here in your first semester, we speak about any problems, any disturbance in the patient's body depends by the any outside causes, and usually they have a mechanical nature. But not forget that trauma include burns. Trauma include any causes of burns. It can be high temperature burns by chemistry, by some any radiations and some others. Sometimes we can check any frost bites. Let's check into your windows who present in Russia, and all of us who present here, for example, in Kursk, we wait the spring so much, and we have so long winter. That's why frost bites, and sometimes it's actuality in our countries. That's why if our patient have injuries which caused by the different traumatic um, different traumatic powers like this from the different natures, for example, fractures and any burns, fractures and frostbites. This is a combined trauma. And don't forget when you answering us in exam day, don't forget this for describe and make give us the well definition of all of this term. I describe you this slide now, and you can read. If you don't understand me, it depends by my English level, my definition of all of these things. You can read it another. But if you speak about the polytrauma, generally you must know. Maybe you don't want to be a traumatologist in future, but you must have some base knowledge in this about this condition. Polytrauma. Here we speak about the philosophy of the treatment. First of all, we must understand the degree of polytrauma. We must understand which of these injuries more dangerously for our patient, and which of them we must treat firstly or maybe stabilize the general condition of your patient. How much of students present in the pub? All of you have some party in this pub. Give me this, Vanuka, send me please the geotag, and I read it to you and process my election there. If you speak if you speak about the mortality, isolated trauma, it's near than 10 persons. If you speak about the multiple trauma, 10 persons, and combined trauma, you check the highest mortality on all combination kinds of injuries. All throat patient is died after combined injury, combined trauma. And where these things happened, combined trauma, usually after some auto catastrophe, maybe some problems and maybe something which happens in the factories. In the wars, these things happen too. In a routine life, we don't check this trauma so often. If we speak about the where usually happened depending by the segments which oftenly injured in a combined or in a polytrauma. You check this interesting figure of a human, and you check that most oftenly which combinations we check. It's a lower extremity, it's a tibia and femoral area, it's an abdominal cavity, chest cavity, and some problems in the skull. Maybe it's some subarachnoidal hematomas, maybe other things, but all these things usually according by any localizations of the skeleton trauma too. That's why if you want to classify it, I told you about this few minutes ago. And when if we want to repeat it, it's a isolated trauma, multiple and combined. Sometimes when I read the foreign statutes and literatures, the authors name all of these terms by the polytrauma and just give us the definition into the text. In Russia, we decide like this, that maybe for us more simply that we named different combination of these problems um, by the different terms. Why I can change the slide? Stages. Usually, if we speak about the high number of skeleton trauma, we have the topic bleeding, I think so in next semester, but all fractures or any disturbance in any bones, this is first of all, don't forget, I told for my students that the bones is not the stones, yeah. That all bones are organs too. They have her metabolism, they have her special criteria, and they have any ways for vascularization. If we speak about generally about the kinds of bone tissue, we have two of them. It's a compact and spongious. Spongious into the bony canal, compact made this bony canal. And all of these things into the bony canal, we have a arteria interossa. And the size of this artery depends by the general size of the bone. And for example, if our patient have a fracture in the mid-shaft femur, for example, immediately, it doesn't mean in the next few 5 or 15 minutes, our patient lose near than 1 liter of blood. That's why the mid-shaft femur we named like shockogenic zone. And it's just a single fracture. And in a polytrauma definition, we told that our patient must have another fracture which localized anywhere else. For example, let's decide that the patient have a fracture of humerus bone in each side. That's one. Let's sum in the volume of your blood loss. 1 liter in the femur and near than 30 milliliters in the humerus. That's why summing 1 liter and 3 point, or maybe 1 liter and 1/2. How much of blood we have? All of you tell me that 5 or 7 liters. No, we have near than 10% of our body weight blood. But I think that you agree with me that 1 liter and 1/2 it's too much. That's why it's near than 25% of all our blood loss. And our patient have a the second degree of shock. And if we speak about the definition and feel all of these things, if we see them, if we want to describe the general conditions of our patient with the polytrauma, usually when we describe them, we must base on knowledge of her shock degree. Yes, and we think about the shock first or second. What's how our patient see it? Her skin so pale. We check the heartbeat rate. We have a high breathe, and we have a low blood pressure. We can check that the lower index more near than 1 or maybe 1.2. And all of these things told us that our patient have a second or maybe higher degree of shock. Here, this I read this lecture 1 year ago, and I know the maybe red line of this of this lecture, and I read and describe all slides before then show them. That's why this slide show you how much of blood our patient lose if our patient have any localizations of the fracture. That's why you check that maybe if we have a mixed trauma, abdominal and a fracture, that's why our patient lose near than 2 or 3 liters. And this critical blood loss guaranteed that our patient have a terminal degrees of shock. And if we non-transport them in a hospital for a so short period, or maybe we named it like a golden hour after trauma, the mortality into this period the highest in all treatment. This thing show you the interesting picture. It's some car crash, and if we speak about the first peak of death, it's a severe head injury, brainstem, high cord injury, hit aorta, and massive blood loss. If our patient have these things and these things happen with our patient in a place of accident, sorry, hello Peter, happen it so often and so fast. If our patient have not any this so high problems, we have a second peak of that. It's intracranial bleeding, chest injury, abdominal bleeding, pelvic and multiple lip injury. And after that, and after second peak, if our patients stay alive, we have the rule of golden hour. If before that the patient have some ununderstood things into this gold hour, you must stabilize your condition generally to satisfactory or maybe hard, but no agony, and you must stabilize all function of your all systems. That's why golden hour. You check it and you can read it. When I made a new film about the James Bond, I named him like a gold hour. So cool number. But all of these things about in a polytrauma and all red line into this lecture, it's a maybe philosophy. It's a philosophy of treatment. If you understand the main steps into this philosophy, you can make first of all the well plan of investigation, and secondary you can make the well plan of the treatment and maybe any consultation with other doctors. And we have 10 platinum minutes, yeah. That's why we must make all activities. And a third peak of that, it's happened after 3 or 4, maybe 5 days, when the patients have a so high number of open injuries, when we have a decreasing of the immune status, and our patients start, and we start to check a sepsis, and we have a polyorgans dysfunction, and these things guarantee that our patient can stay alive in the first peak. But I don't check any acute or maybe flash kinds of sepsis. Usually we need 3 or 4 days. That's why our patients stay alive, and we can stabilize them generally and start to check the organ defect or organ fail. One of these things you can check what? You can check the problems with the traffic of our patient. First of all, the one we check that any second patients died before arriving to the hospital, because in the emergency car it's so difficult for stabilizing the general condition of our patient satisfactory. All of decreasing of your general conditions depends by the unstable position of the costal fragments into the bones, unstoppable bleedings, internal bleedings. When we don't understand from which organ or maybe where the target of this bleeding, we just try to compensate the losing of blood, but we can stop the bleeding. Sorry. Group, let's decide like this. Some minutes. I take your time. Yeah. Some of you send me a message that I have some problems, I have some answers, and something else. First of all, I'm a doctor and I'm a teacher who have a working time. First of all. And I'm not answering on any messages in my non-working time. Else, if you are present here and you have any address, I understand that it's more comfortable for you to send a message for a doctor, stay at home, and give a definition or maybe decision of your other problems. Let's decide like this. I'm not answering on a WhatsApp questions. I'm you all of you work nowadays work in a native form in the departments. Some of you create the patients, and that's why I'm not a chat bot in WhatsApp. Please, let's stop to send me any messages. University don't give me the rules in my special paper like a teacher that I must answer on these questions. Mhm. I think that you understand. The third process of patients died after in the first 4 hours presenting in the hospital because the poly organs failures happen so fast and so deep and we can save. And you check the 20% of the patients we lose them in the first 3 weeks. Why? Because it's a third spike of death, it's a septic problems, it's other things which happened after general stabilization of the patients. That's why all of these things. Our priorities: life salvage, limb, and salvage of total function if possible. But in the first golden hour, it's our first step. We must save the patient's life. In our near then or maybe in the period from second spike of death to first spike of death, we must live safe. And if our patients stay alive, our next steps, it's a total rehabilitation of our patient, maybe reduction of problems with other functions in the extremities and in the organs for don't have any problems. Criteria of traumatic shock, it's we have Algomer index and we have blood pressure to pulse like this. And if we have problems, how we can understand which degree of shock our patient have. I repeat this information I forgot, or maybe too much of teachers told you about this in a few number of previous departments. And the numbers of these criteria can be different in all departments. Why? Because if you want to find something in the medicine, or maybe try to be an author of new book, you just change the, you decided no 19 millimeters, yeah, maybe 88. I think it's more adequately because I'm an author of this book. Here we give you the mid numbers of blood pressure. And the blood pressure, the decreasing of these things give us the stage of shock. And don't forget, it's just blood pressure. We must check the pulse. The pulse will be so fast, and these things give us the Algover index. And these pictures show you where we check the stroke. If the patient have a blood pressure lower than 90, we have some problems where we have some problems in the intestines. If the blood pressure lower than 17, we have decreasing of speed of perfusion and reperfusion in the kidneys. And if the blood pressure lower than 15, the firstly subcompensated and secondary critical ischemia into the brain happen. That's why let's check your patient's blood pressure and let's increase them for decrease the stage of shock. Shock, maybe you have a different and you know the different types of the shock: hypovolemic, traumatic, pain, anaphylactic and others, sometimes endogenous intoxication shock. But generally, the pathophysiology is based of these problems. It's a problems with the oxygenation of tissues. For example, the hypovolemic shock. We need each number of erythrocytes which transport the oxygen from the lungs, from the alveolus to the tissues. If we lose some number of these erythrocytes, finally we have a hypoxia in each organs. If the number of these erythrocytes decrease critically, this hypoxia transforms himself to necrosis, gangrene, and others. For example, different situation. Our patient have a pain shock. Pain shock guaranteed that we have a peripheral vasoconstriction, we have a changing of the distal vessel size, and what's happened finally, we have not maybe the normal number of erythrocytes. All of them get the normally level of oxygen, but they can't transport them to the tissues because the roads, maybe the vessels, is so small. That's why we have a sludge syndrome. Yeah? Too much of erythrocytes staying like a cars near the MacAuto for eat any burger, and we see, and we see generally the hypoxia, and finally we see the necrotic changes, gaming kind of anemia. What's happened? We have a normally level of erythrocytes. We have a normally level of other things, but any poisons connect with the erythrocytes and blockage your possibility for transport the oxygen. For example, if the patient inspired too much of CO gas, uh, CO gas hate which girl in the world, Greta Thunberg. And if the patient inspired too much of this gas can connect with the erythrocytes and blockage her possibility for transport the oxygen. We have a normal blood of erythrocytes, normally level of hemoglobin, but peripheral hypoxia, and finally general, maybe we can name it necrosis happened. That's why a different nature and a different pathogenesis of shock, but generally the base all of them, it's a decreasing of periperfusion, oxygenation of the tissue. Pain, bleeding, trauma, and stress. Stress, it not does it mean that you feel stress if you can buy the new models of Nike Air Max because Nike finished her work in Russia. The stress is not like this. The stress sometimes, so you can see them with any psychiatric problems because the stress it's more deeper torment than now. We have just 40, 51 students. Are you understand me when I wanna told you my English and others?
Yes, sir.
Yes, sir.
Mm, thank you. That's why let's go next. It's the risky factors of traumatic shock. We understand that if you take the two same patients, one of them have more lower levels of red blood, and they lose the same liters of the blood, the the degrees of shock are different too. Sometimes we have some problems in the patient's coagulation system. And one of these patients, maybe for example, the patients have the same size of wounds, for example, and they allude if some of patients have some problems with it. We are present here. You're students. I'm a teacher. Yeah. Who's of us more happy now? Me or you? Opinions? No. The men who present near my apartment. if you drank some small level of alcohol in the mid time of the day, all evening you are so happy. Hmm. Okay, and if this one of these men have any problems, any rules, and one of these men have some problems with the calculation system, and second, no, we understand that the level or the timing of the bleeded more longer in the first case. That's why this patient lose the more volume of the blood, and that's why he have the high degree of shock. Here, too much of definitions about the hematocrit and others. I told you like this. I show you the slides, and after a few seconds, you forgot about all of these numbers and so on. For starts to understand something, you must train in yourself, like I named it like an analysis game. It not does it mean that you send your analysis to somebody. No, it means that you check the analysis with the different diseases every day and try to understand what does it mean. Decreasing of erythrocytes, but normally level of hemoglobin. The increasing of leukocytes and young form of them into the blood. Increasing of FSR. I find that some site in the internet, I forgot. But if you training yourself like this, all of these numbers, those are big numbers, you start to understand. More simply, if you understand something, if you try to learn and fix it into your brain, any doses and any things without any understanding, we have these things, and you can save some app, and let's make some brain space for save some others. Syndromes in a multiple injury, it's immunodeficit which happened after 3 or 4 days in 1 week, and depending by this immunodeficit, we have some pneumonia, and finally we can see some generally purulent problems like toxemia, toxicopemia, and finally we can check a sepsis. And if and why these things so difficult? Because we have a mixed form of different microorganisms, different bacteria, and that's why we must use the mixed form of antibiotics in a high, maybe more higher than therapeutic doses. If we speak about the philosophy principles of polytrauma treatment, we must use the three principles, for example. First, principle of domination or critical trauma. You must choose and then understand which of these injuries is more dangerously for our patient. I start my lecture from the any case. Femur fracture midshaft in the distal phalanx on the first Generally, we must name this fracture combination of these fractures like a polytrauma. But which of these fractures you treat first? I think that you start from the femoral trauma, because this femoral trauma more dangerously for a patient, and this fracture can kill them. First time, no problem. This thing can wait 30 minutes when you made something with the fracture of femur. Principle of combination. Don't forget that you choose the most dangerously for your patient injury, but don't forget that you must treat all of them. And don't forget about the first two. We have in a traumatology, when the patient admitted to us with the different combinations of polytrauma, we have maybe we name it like a gentleman cases. The patient admitted to you with the chest trauma, with the femur or maybe pelvis, you treat all of them and forgot to make some small X-ray of the pelvis when you find the fracture of the first or maybe other phalanx in a fingers. Why? Because now in this situation, this injury is not so critically dangerous for our patient, but you don't forget about it. In principle of single trauma, you must treat you must treat this trauma, then this thing is an isolated injury. You must fix them, you must operate them primary and fast. Trach severe, you can see that. you you must sort if you have too much of patients. You must sort them by 4 categories. First of them, it's a critical cannot wait, target, less serious injuries, and expectant. That's why, for example, too much of patient admitted to your hospital. Let's try to classify them and let's give the first aid for the most difficult. How to triage? How you must understand it. First of all, can your patient walk? Yes, no. In the hand, is the patient breathing? Yes, no. Check the circulation. Capillary refill more than 2 seconds, on low than 2 seconds. All of these things, after that, you understand it's an emergency patient or this patient can wait. I forgot we have a special classification. I don't find the slides, sorry, in English, and I can translate, but I like, why? Because we have a color dependent, and we have understanding what we must make and the timing, how much our patient can wait our help start. You see that first, second, and third, it's a 1 hour gold hour needed help. Other patients can wait 2 or maybe more hours. These things describe us this situation too. I show you and insert this slide into our into our lection, but if you want to understand which degree or maybe which kind of coma your patient have, usually you need a consulting of any anesthesiologist and rheumatologist patient. But if you have not anybody around of you, like with my group, we today describe the pelvic injuries, and I try to show and I describe to all of my group that the trauma generally it's so simple if you understand some rules. And don't forget that you after 1 year you start to kill your patients. Don't forget about it. And let's kill them by the signs. That's why you must give him the well combination of the shock. Uh, if we treat the polytrauma with the different kinds of the injuries, we must have a special group of the doctors. And who's played here, it's a minimal team, for example. Who play here the first role is anesthetic reanimation. Why? Because just these doctors treat the patients by the syndromes. They don't need any case disease history and some others. They have some syndrome and they must cupate. Anesthesia, first of all, if we speak about the shock, we must give our patient the well pain management. That's why we maybe need any sedation and some other. That's why anesthesiologists play a great role. General surgeon. Sometimes polytrauma according with the problems in the abdominal cavity. That's why for investigate and treat them, we need the general surgeon. Traumatology, extremities, chest, neurosurgeon. It's a some understanding primary and secondary understanding. Intrascal problems, maybe it's a some disturbance in the spinal column with some problems in the sensitive and motoric areas of our patient which need the emergency operation. Thoracic surgeon, if the traumatologist can help our patient fully for maybe suturing of the lungs, for example, and some other, we needed thoracic surgeon. Maxillofacial surgeons, we needed if the patient have some traumatologist non-treat the mandible and these joints too. It's a these kinds of surgeons and urologist because we have some special organs, which were present retroperitoneal and the patient have some kidneys, the patient have root bladder and the rupture of this problem, so oftenly check and so oftenly indicate when our patient have a polytrauma. First diagnostic plan, first of all, like an anesthesiologist. Don't forget that all of these things must made so fast into the golden hour rule. That's why we must correction of airway, we must check the breathing, check the bleeding, check the damage and central nervous system and full checkup. After this full checkup, we understand which syndromes our patient have. Our patient maybe can breathe himself by himself, or we must intubate them. The rule of third catheters, it's a peripheral vein catheter, it's a central and the catheter into the bladder. That's why we start to make the infusion. We start to make and check the our diuresis for understand the kidneys function, so maybe dysfunction. We must, here it's a position of the intubation when we intubated, but it's another traumatology skills. If you can intubate, that's why you must make the tracheostomy for guarantee that your patient can breathe without any problems. If the patient have any problems into the chest cavity, non-chest pleural cavity, you must make the thoracentesis. You must insert any tubes for guarantee that you uncalibate the lungs. That's why like this increase the breathe areas or breathe spaces into the lungs. Secondary, you must understand which problems, if our patient have them, and in a thorax, which kind of pneumothorax, which kind of gammathorax our patient have. Maybe our patient have a paradoxal breathing or maybe unstable thoracic cavity when the patient have a window kind of these fractures. And maybe the patient have some thoracoabdominal branch. It's not so interesting. Yeah. Look, listen, feel. It's airway obstruction if you non hear, if you non check, and if you non feel. Here you can see the definitions, all of them, and you can see the definition, the problems with the breath that our patient had. Airway, it's not so interesting. Breathing. I want to change this. Yeah. First of all, how we understand that we must operate our patient now from the admitted room to operation. If our patient have a high stage of shock, and if our patient have a massive intracavity bleedings, maybe our patient have a massive intracavity bleedings from parenchymal organs, which of them? Lungs, spleen, kidney, and other. And we understand that temporary methods of temporary stop them non-work in this situation. That's why we made the emergency operation on the next 10 weeks or maybe more after patients admitted. Compression of the spinal cord, we must reduce all of these problems in the first hour. Secondly, yeah, we must operate him, but we can do that in the first 6 hours. Before that, we try and can stabilize your general condition, maybe use any cast. Our patient having any intra cavity massive bleedings. That's why we can wait some hours. If our patient have open fractures and anything else, we can fix these fractures by the skeleton traction and maybe special apparatus of external fixation, and like this stabilize the general patient's conditions. Third group, 3 days, and we weigh the problems. If our patient have some problems with the hemostasis, that's why we wait 3 days. Anesthesiologist stabilize them, and after that we can operate him. and we can, and I told you that this more comfortable operations than emergency first 6 hours operation. Why? Because if we operate these patients in the first time, the first 6 hours, these patients from which groups? From the second spike of death, or maybe first spike of death, and I show you previously the persons of the of non so cool fractures, non so cool results. That's why these slides give you maybe how we named it, the map of any organs. That's why maybe the number of investigations which you must make for understand what's happened there. Which chat? Somebody tired. Emergency treatment, which patient you can take in the operation room. You check that if the gamma globin needed lower than 18, this is so dangerous for your patient. These things define us. It's a second degree. We check the problems which some fraction of intra-blood proteins and others. And fourth group, this is the more positive prognosis, because you must operate them in first 2 weeks, and reconstruction operations you can do that on the first step. If with the first group you just stabilize the fracture by something, temporary methods, here you operate your patient with the final kinds of metal constructions. Osteosynthesis we use, first of all, depends by the kind of the bones injury. If we speak about the organ osteosynthesis, we use a non so invasive kind of metal constructions. Usually it's some external fixation apparatus. We don't use any plants and screws. Why? We try to minimize the size of our approaches, because all our approaches, it's the next causes of bleeding, and this is decreasing of our patient general condition. Shock. Don't forget that when we treat a shock, first our steps, it's a reduction of losing of the water and blood. That's why we must make the blood circulation, which starts to inject them the crystalloid and colloid solutions. How much more deeper the reanimatologist told you about this in the next year, but here I told you like this: crystalloid twice than our patient lose. You must liquidate, you must limit the pain. That's why you must use immobilization, you must use the narcotic drugs for give pain management for our patient. Next things, it's your tasks in the first steps of this treatment. You must support blood circulation, quality of blood content. That's why you must have a normal condition, you must have the well hematocrit, and you must you must use, if you need so high speed injection intravenous, you can use 2, 3 or more catheters. It's a program of infusion. I told you like this. You didn't understand and forget all of these numbers after a few minutes, but you can make the photo, or we resend these things, this information in our Moodle. That's why these things don't tell you anything. Why? Because all of this needed volume depends by the here concrete situation in the place, in your apartment, in your in your hospital apartment. That's why you see that how much of our patient lose. That's why crystalloid twice than our patient lose, colloid the same like our patient lose. Immune components, if we try to decrease any septic problems, that's why we must use the plasmapheresis, hemofiltration, immunopharmacotherapy, we can see some special drugs which increase the any conditions of immune system, and we can use the autografting in the blood cells. This is not so interesting. No. And if we speak about the problems of the polytrauma and the first golden problems, first of all, sometimes if you need the high and intensive blood transfusion, you have not any needed group and rhesus factor blood into your hospital. Firstly, secondary, you can't reduce the inspiration expiration kind of or maybe function of your patient. And secondary, after massive blood transfusion, you can find the special intravessels coagulation. That's why you must use the anticoagulant drugs. And all of these things change the pH, generally pH of your patient's body to acidosis and alkalosis, and you must use another special drugs for change this balance. Me, like a traumatologist, starts to play any great role in a patient's life with the polytrauma after first 20 or 30 minutes, when the reanimatologist intubate our patients, made insert all her needed catheters. Next, my step, I start to fix it, or maybe immobilize, or maybe stabilize the fractures and understand volume of skeleton problems. If I need any consulting of each doctors, I call them to general surgeons, neurosurgeons, and others. But golden hour, it's a great rule. Platinum 10 minutes, it's a great rule too. I told you that on my duty time, I lose too much of patients with the polytrauma into these periods. That's why let's activate yourself, let's activate your brains if this patient admit to your hospital, and let's treat him depending by the philosophy of domination principles and depending by her category after your first examinations. 15 minutes. That's all, students. Fast lecture. Your brain not so hard, and you can be free early. Have you any questions to me?
No, sir.
That's why you process your pub party, yeah? And all of you send me these pluses. Take care of you and see you in the next lections.
Thank you,
Thank you,
sir.
sir. До свидания.
See you.
До свидания.